1, 2,
And review 70-year-old female.
Oh shit, almost got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's
300 please.
I'll keep you on guard again.
Pulse check. No pulse.
no more pulse.
Yeah. Where the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
A patient's heart monitor suddenly shows like a widening QRS complex. You're standing at the bedside in the ICU, the pressure is dropping, and you have exactly minutes before they go into fatal VFib.
Right. And your first instinct is that this is a primary cardiac event.
Mm-hmm.
But the culprit isn't the heart at all. It's the kidneys.
Yeah, and by the time you realize that, the window to save them is closing. Welcome to the deep dive.
Today, we are entirely focused on what happens when the kidneys fail, and more importantly, what you do about it right this second. We are taking a massive stack of nephrology and critical care literature and aggressively applying the 80-20 Pareto principle.
Yeah, we're cutting out the noise entirely.
Exactly. We are looking at this strictly through the lens of, an elite ICU intensivist and a critical care nursing instructor.
That's right. We are speaking directly to you, the experienced ICU professional. We're not here to review basic anatomy or, tell you that 1 kilogram of weight equals a liter of fluid. You know that.
You already know that.
We are here to connect the deep molecular pathophysiology directly to the bedside alarms, the hemodynamics, and the immediate clinical decisions you have to make.
And we've got a massive amount of clinical terrain to cover. So we are starting with the rapid, explosive threat of acute kidney injury, or AKI.
Right.
From there, we'll explore the insidious systemic poisoning of chronic kidney disease, CKD. Then, when native function is completely lost, we'll break down the exact physics and hemodynamics of renal replacement therapies.
Like standard hemodialysis, peritoneal, and CRT.
Exactly. And finally, we will navigate the razor's edge of the immediate postoperative window in kidney transplantation.
Okay, let's unpack this. We have to start with AKI because this is the immediate threat. This is the sudden crash. What is the fundamental 80-20 overview that an ICU nurse needs to anchor on here?
Well, AKI is an abrupt, rapid drop in kidney function happening over hours to days.
Yeah.
And it matters because when it develops in critically ill patients, specifically in the ICU, the mortality rate skyrockets to 80%.
Wow, 80%.
Yeah. Anyone with severe hypovolemia, prolonged hypotension, or nephrotoxin exposure is at immediate risk. I mean, the kidneys take up a massive 20 to 25% of total cardiac output.
Right.
They're highly vascular, highly metabolically active, and therefore incredibly vulnerable to ischemic hits.
I want to get granular on that ischemic hit, actually. Let's trace the pathophysiology from the trigger all the way to the decompensation that I'm seeing on the monitor.
Okay.
If we look at prerenal AKI, the perfusion problem, what exactly is happening at the cellular level when the patient's blood pressure drops?
So let's use sepsis or cardiogenic shock as our trigger. Systemic mean arterial pressure drops. The kidneys are suddenly underperfused.
Got it.
The physiologic change is a drastic reduction in blood flow to the glomerulus. The kidneys immediately attempt to compensate. The macula densa cells in the distal tubule sense a drop in sodium chloride delivery because less blood is being filtered, and they signal the juxtaglomerular cells to release renin.
Okay, which kicks off the renin-angiotensin-aldosterone system, or RAAS, the body's ultimate volume preservation cascade. But how does that specifically protect the kidney's filtration in the short term?
Well, through angiotensin II. Angiotensin II is a potent vasoconstrictor, but it specifically targets the efferent arteriole, the vessel carrying blood out of the glomerulus.
The exit pipe.
Exactly. By constricting the exit, it builds up back pressure inside the glomerulus, artificially maintaining the glomerular filtration rate, or GFR, even when systemic blood pressure is low.
Oh, wow.
Simultaneously, the kidney produces local prostaglandins to dilate the efferent arteriole, the entrance. Wide open entrance, pinched exit. Pressure is maintained.
Which explains why giving NSAIDs or ACE inhibitors to a hypotensive patient is a death sentence for their kidneys. I mean, NSAIDs block the prostaglandins, so the entrance slams shut.
Yep.
And ACE inhibitors block angiotensin II, so the exit blows wide open. You lose all your filtration pressure.
Exactly. You strip away their only compensatory mechanisms. But even without those drugs, if the hypotension persists, this compensation eventually fails.
And that's the decompensation phase.
Right. We cross the line from a prerenal state, which is just a thirsty kidney that you can fix with IV fluids, into intrarenal damage. The prolonged ischemia starves the renal tubular cells of oxygen.
Let's talk about those tubular cells, specifically in acute tubular necrosis, ATN. Why are they so vulnerable to hypoxia?
So the proximal convoluted tubule and the thick ascending limb of the loop of Henle are packed with sodium-potassium ATPase pumps. They have massive ATP demands to reabsorb electrolytes.
Right.
When ischemia cuts off their oxygen, ATP production halts. The pumps fail. The cells swell with sodium and water, their membranes rupture, and they undergo necrosis.
And when those cells die, they don't just disappear, they physically cause a problem, right?
A massive problem. The dead epithelial cells slow off the basement membrane. They mix with cam-horsefall proteins in the lumen and clump together, forming what we call muddy brown casts.
Ugh, muddy brown casts.
Yeah, and these casts physically obstruct the tubule. So now, even if you restore blood pressure, the fluid can't get through the tubules. The pressure backs up into Bowman's capsule, neutralizing the filtration gradient. GFR drops to near zero.
Which perfectly explains the classic clinical finding, Oliguria. Less than 400 milliliters of urine a day, because the pipes are literally clogged with dead cellular debris.
Yes, but here's a massive ICU pearl and a really common diagnostic trap. 50% of AKI is actually non-oliguric.
Wait, really?
Yeah, meaning the patient is still putting out a liter or more of urine a day, but they are still in acute renal failure.
Wait, if the tubules are clogged and dead, how are they making that much urine?
Because in non-oliguric AKI, the damage is patchy. Some nephrons are completely blocked, but others are just damaged enough that they lose their ability to concentrate the urine.
Oh, I see.
The surviving tubules are acting as passive broken pipes. They can't reabsorb water or clear nitrogenous waste, so water just pours right through them. Do not look at a full Foley bag and assume the kidneys are fine. You must look at the serum creatinine and the clearance of wastes.
Speaking of waste, when GFR drops, nitrogenous waste build up in the blood, so azotemia. How does that uremic toxicity actually present neurologically at the bedside?
It's insidious. It usually starts as lethargy and an inability to concentrate, but uremic toxins directly interfere with neurotransmitter function and cause localized cerebral edema.
Yikes.
If left unchecked, this uremic encephalopathy escalates to asterexis, that classic flapping tremor of the hands, then to myoclonus, seizures, stupor, and eventually coma.
Let's shift to diagnostics. I have a hypotensive patient. Their urine output is dropping, or, maybe it's fine, but I'm suspicious. We use the IFLE criteria, risk, injury, failure, loss, ESRD, which relies heavily on serum creatinine. But there's a problem with creatinine in the acute setting, isn't there?
A very significant one. Serum creatinine is a lagging indicator. It depends on steady-state kinetics.
Right.
If a patient's GFR drops to zero right this second, their serum creatinine won't peak for another 48 to 72 hours. It takes time for the muscle breakdown product to accumulate in the blood.
So it's too late.
Exactly. If you wait for the creatinine to rise before you intervene, you are already days behind the actual injury.
So what's a faster diagnostic tool? You mentioned the urine earlier.
The urinalysis is your real-time window into the kidney. We look at the specific gravity and the urine sodium. Let's look at pattern recognition.
Okay.
If you have oliguria, a high urine-specific gravity, say 1.030, and a very low fractional excretion of sodium, less than 1%, what are you looking at?
Well, that's prerenal. The kidney tissue is still alive and healthy. It's concentrating the urine to hold on to water, and it's aggressively reabsorbing sodium to boost blood pressure.
Spot on. Now, what if you see oliguria, but the specific gravity is fixed at exactly 1.010, and the fractional excretion of sodium is greater than 2%?
That's intrarenal. That's ATN.
Right.
The specific gravity is 1.010 because that is the exact osmolality of plasma. The kidney has completely lost its countercurrent multiplier mechanism in the loop of Henle. It can't concentrate or dilute the urine. It's just passively mirroring the blood.
Exactly.
And the sodium is high in the urine because the dead tubular cells literally cannot reabsorb it.
You are distinguishing between a kidney that needs volume resuscitation and a kidney that has suffered structural death and needs time, restriction, and potentially dialysis to recover.
Let's translate this into our nursing priorities. If I'm managing an established ATN patient in the Oliguric phase, fluid balance is a nightmare. I can't just keep giving them normal saline. How do we precisely manage their fluid restriction?
The implementation standard is rigorous. You calculate their fluid allowance for today based on yesterday's losses.
Okay.
You take all of their output from the previous 24 hours, urine, emesis, diarrhea, surgical drains, and you add 600 milliliters to account for insensible losses.
Like fluid loss through respiration and diaphoresis.
Right. So if they put out 400 milliliters total yesterday, they get exactly 1,000 milliliters of total fluid today. That includes all IV medications, flushes, and oral intake.
What about forcing the kidney to work? Like, if they're fluid overloaded, can't we just hit them with a high-dose Lasix strip?
See, this is where intensivist thinking is crucial. Loop diuretics, or osmotic agents like mannitol, might be attempted very early in the injury to establish urine flow. But if intrarenal damage is already established, if the tubules are dead and obstructed with casts, pushing massive doses of diuretics is actively harmful.
Because you're whipping a dead horse.
Worse than that, diuretics don't just fail to work on dead tubules. High doses can cause systemic venodilation and actually decrease renal blood flow further, worsening the ischemia.
Oh, wow.
Plus, high-dose loop diuretics in the setting of renal failure carry a massive risk of ototoxicity, causing permanent deafness.
That's terrifying.
Well, let's talk about the immediate killer. We open this with a widening QRS complex.
Yeah.
The potassium is 7.8. The patient is in the Oliguric phase of AKI. From an intensivist mindset, the problem is severe hyperkalemia. The failing physiology is a disruption of the resting membrane potential. I want to dive deep into that. Why does high potassium stop the heart? It all comes down to cellular electrophysiology. The resting membrane potential of a cardiomyocyte is largely determined by the concentration gradient of potassium across the cell membrane. Normally, potassium is high inside the cell and low outside.
Right.
This creates a resting potential of about negative 90 millivolts. The threshold for an action potential to fire is around negative 60 millivolts.
So there's a 30 millivolt safety buffer.
Correct. But in AKI, the kidneys can't excrete potassium. It builds up in the extracellular fluid. This alters the ratio, causing the resting membrane potential to become less negative, say negative 70 millivolts. Now, the cell is resting dangerously close to the threshold potential. The heart becomes hyperexcitable. This manifests initially as tall, peaked T waves on the ECG.
But then the QRS widens. Why does an excitable cell suddenly slow down its conduction?
Because of sodium channel inactivation.
Yeah.
When the resting membrane potential stays chronically elevated, the fast sodium channels responsible for depolarization essentially get stuck in an inactivated state.
Oh, so they can't fire.
Exactly. Conduction velocity through the myocardium plummets. The QRS widens. The PR interval lengthens until the P wave disappears entirely. Without immediate intervention, this degrades into a sine wave pattern, ventricular fibrillation, and cardiac arrest.
So the immediate threat is fatal arrhythmia. I need to know the exact priority ranking for intervention. First, next D, and then what is first?
First, administer few calcium gluconate or calcium chloride immediately.
To lower the potassium.
No. Calcium does absolutely nothing to the serum potassium level.
Really?
It works purely on the electrical stability of the heart. By flooding the extracellular space with calcium, you raise the threshold potential of the myocytes. If the high potassium moved the resting potential up to negative 70, the calcium moves the threshold potential up to negative 40.
Ah, so you restore that 30 millivolt safety buffer.
Exactly. You stabilize the myocardium within minutes, buying yourself time to actually fix the potassium.
Okay, the heart is protected, but the potassium is still 7.8. What is NEC-XT?
NEX-XT. You must shift the potassium out of the bloodstream and hide it inside the cells. We do this by administering IV regular insulin concurrently with 50% dextrose.
Okay, how does that work?
Insulin forcefully activates the sodium-potassium ATPase pumps on the cell membranes, driving potassium intracellularly. The dextrose is just there to prevent fatal hypoglycemia. You can also administer high-dose nebulized albuterol, which stimulates beta-2 receptors to also drive potassium into the cells.
And what if they're acidotic?
If they're severely acidotic, IV sodium bicarbonate will exchange hydrogen ions out of the cell for potassium ions going in.
But all of those are temporary, right? The insulin wears off, the cells equilibrate, and the potassium leaks right back out into the blood in a few hours.
Exactly. They are bridge therapies. Which brings us to then. You must actually remove the potassium from the body. If the patient makes urine, you could try diuretics, but in Oliguric AKI, that won't work.
Right.
You can use gastrointestinal binders like sodium polystyrene sulfonate or chiexlate, which swaps sodium for potassium in the gut and excretes it via diarrhea.
But chiexlate takes hours or even days to drastically lower potassium. What about the newer binders, like Pateromar or sodium zirconium cyclosilicate?
Never use those for a hyperkalemic emergency. Their onset of action is far too delayed. They are strictly for chronic management. If you have an Oliguric AKI patient with a potassium of 7.8 and ECG changes, and shifting agents aren't holding it down, the definitive treatment is urgent hemodialysis.
Wow, okay. We've covered the fastest killer, the potassium, but what is the most common cause of death in AKI?
It's infection, specifically respiratory and urinary tract infections.
Wait, hold on. If infection is the actual killer, but we are obsessively watching the monitor for peaked T waves, how are we missing the sepsis?
Because uremia causes profound immune dysfunction. Uremic toxins impair neutrophil chemotaxis and phagocytosis. The white blood cells essentially become sluggish and blind.
So they don't fight the infection.
Right. Because of this, AKI patients have a blunted febrile response. They might have overwhelming pneumonia or a raging bloodstream infection, and their temperature is completely normal, or even hypothermic.
So I can't wait for a fever spike. I have to look for subtle signs of deterioration, like rising lactate, increasing vasopressor requirements, unexplained tachycardia, or worsening mentation.
Precisely. And when you do start antibiotics, you run into the next intensivist trap. The kidneys excrete the majority of our broad-spectrum antibiotics. If you give a standard dose of vancomycin or piperacillin tazobactam to a neuric patient, it will build up to highly toxic levels, potentially causing further tubular damage or neurological toxicity.
So every medication must be aggressively renal adjusted by pharmacy.
Yes, exactly.
Let's talk escalation. Beyond the potassium, what else triggers a rapid response or immediate intervention in AKI?
You must watch for uremic pericarditis. As urea builds up in the blood, it causes severe inflammation of the pericardial sac. You'll hear a scratchy pericardial friction rub on auscultation, and the patient will complain of pleuritic chest pain.
Oh, man.
If that inflammation leads to a massive pericardial effusion, the fluid will crush the heart.
Cardiac tamponade.
Yes. The clinical presentation is Beck's triad: muffled heart sounds, jugular venous distension, and severe hypotension. The right ventricle physically cannot fill with blood. This requires an immediate emergency pericardiocentesis to drain the fluid, followed by urgent dialysis to clear the urea.
Okay, let's synthesize this. If I'm giving report to the next shift, I want to hand over the core intensivist thinking for AKI. Let's hit the 5 fundamental takeaways.
So number 1, core pathophysiology. Decreased perfusion or direct toxin exposure damages the renal tubules, leading to ATP depletion, cellular necrosis, cast formation, and an abrupt halt to glomerular filtration. Number 2, key assessment finding. Oliguria, less than 400 milliliters per day, accompanied by fluid retention, bounding pulses, and uremic encephalopathy. Though remember, 50% can be non-oliguric.
Right, the trap.
Number 3, most dangerous complication. Hyperkalemia, altering the resting membrane potential, causing fatal ventricular dysrhythmias.
Which we treat first.
Exactly. Number 4, priority nursing action. Strict intake and output and rigorous fluid restriction calculated as the previous 24-hour total loss plus 600 milliliters for insensible losses.
And the final one.
Number 5, most important treatment. Administer the 5th calcium gluconate immediately for hyperkalemic ECG changes to restore the myocardial threshold potential, followed by insulin and dextrose to shift the potassium, and dialysis to remove it.
Our one-sentence clinical picture for AKI.
A hypotensive ICU patient suddenly stops making urine, swells up with third-space fluid, and develops a widening QRS complex on the monitor.
And the ultimate clinical trigger rule.
If you see a widening QRS with oliguria, think life-threatening hyperkalemia, and do administer 4th calcium gluconate immediately.
Incredible. That covers the explosive, rapid crash. We've resuscitated the 48-hour disaster. But what happens when that inflammatory and destructive process is stretched over 15 years? Let's transition to the slow burn of chronic kidney disease. What is the 80-20 overview here?
Well, chronic kidney disease is the progressive, irreversible destruction of nephrons. The clinical definition is a GFR of less than 60 milliliters per minute lasting for longer than 3 months. It is an epidemic.
How many people are we talking?
More than 26 million American adults have it, and the vast majority have no idea. The top 2 drivers responsible for nearly 75% of all cases are diabetes mellitus and hypertension.
To understand the pathophysiology, we need to look at how the kidney handles chronic stress. I like to picture the glomerulus as a delicate coffee filter under pressure. If you have chronic, uncontrolled hypertension, you are subjecting that delicate endothelial filter to immense barotrauma.
Right.
That's a perfect mechanistic analogy. The chronic high pressure creates shear stress on the glomerular basement membrane. It literally tears the filter. This allows large proteins like albumin, the coffee grounds in urine allergy, to slip through into the renal tubules.
But the tubules aren't designed to handle massive protein loads.
No, they aren't. Proteinuria is highly toxic to the tubular epithelial cells. It triggers a massive local inflammatory response, leading to interstitial fibrosis and scarring. The nephrons begin to die off, one by one.
And diabetes does the same thing through a different mechanism. The chronic hyperglycemia causes non-enzymatic glycosylation of the efferent arteriole, making it stiff and narrow. So you get that same back pressure and hyperfiltration injury, destroying the filter from the inside out. But why don't patients feel this happening? Why is it silent until they lose 70% of their kidney function?
Because of the kidney's incredible, yet ultimately self-destructive compensatory mechanism, hypertrophy. When a nephron dies, the surviving nephrons nearby actually enlarge. They vasodilate their efferent arterioles to pull in more blood, increasing their single nephron GFR to pick up the slack.
So they are hyperfiltering to keep the total blood chemistry normal.
Yes. They work double time. The patient feels fine. The BUN and creatinine look completely normal on labs. But this hyperfiltration increases the shear stress on those surviving glomeruli.
A vicious cycle.
Exactly. The harder they work to compensate, the faster they scar and die. By the time the total GFR starts to drop and the creatinine begins to rise, you have already lost millions of nephrons permanently.
And when that decompensation finally hits, we see the systemic poisoning known as uremia. How does uremia present clinically as the disease progresses to end-stage renal disease?
It affects every single organ system. Early on, especially in diabetics, you might see polyuria as the damaged kidneys lose their ability to concentrate urine. But in late-stage CKD, it transitions to anuria. You'll assess uremic fetor, a distinctly urinous ammonia-like odor to the breath caused by urea breakdown in the saliva.
That's very distinctive.
It is. They also develop stomatitis, painful ulcerations in the mouth. Neurologically, the toxins destroy the myelin sheaths of peripheral nerves, causing severe peripheral neuropathy, often described as a burning, restless sensation in the legs.
And the skin changes are profound. CKD patients suffer from intractable pruritus, just relentless itching.
It's agonizing for them. It's not just dry skin. It's caused by uremic toxins, sensory neuropathy, and crucially, the microscopic deposition of calcium phosphate crystals directly into the skin layers.
Into the skin itself.
Yes. In the absolute most severe untreated cases, with BUN levels exceeding 200, the urea concentration in the sweat is so high that it literally crystallizes on the skin when the sweat evaporates. This is called uremic frost.
Wow. Let's look at diagnostics. You mentioned that waiting for the serum creatinine to rise means you've missed the early window. We have to look at the calculated GFR using the MDRD equation. Why does creatinine lie to us in chronic settings?
Because creatinine generation is directly proportional to skeletal muscle mass. Think of a frail 80-year-old woman weighing 45 kilos and the 30-year-old male bodybuilder weighing 100 kilos. If they both have a serum creatinine of 1.5, a novice clinician might assume they have the exact same level of kidney dysfunction.
But the older woman has almost no muscle mass. For her to generate a creatinine of 1.5, her kidneys must be practically non-functional.
Exactly. Her calculated GFR might be 25, meaning she is in stage 4 CKD. The bodybuilder's GFR might be 75, meaning his kidneys are clearing his massive daily creatinine load relatively well. You must always use the calculated GFR, which factors in age, gender, and race to get the true picture of chronic renal function.
And as an early warning sign, before the GFR even drops, we are looking for that protein we talked about. Persistent proteinuria, 1+ on a standard dipstick twice over a 3-month period, is the hallmark of early glomerular damage.
Yes, that is the moment to intervene aggressively to halt the progression.
All right, from a nursing process standpoint, what is the immediate bedside priority for a patient admitted with late-stage CKD? I know the diagnosis is impaired fluid balance and risk for decreased cardiac perfusion, but what are my actual planning and implementation steps?
The primary goal is slowing the progression and preventing fatal complications.
Yeah.
If the patient has an AV fistula or graft placed in their arm in preparation for dialysis, your absolute first priority is protecting that vascular access. You post signs above the bed. No blood pressures, no IV insertions, no phlebotomy in that arm.
Because if you ruin that fistula, you destroy their lifeline for dialysis.
Exactly.
Next priority.
Next is rigid medication and dietary adherence. CKD patients have incredibly complex pharmacology. You are enforcing severe dietary restrictions, low sodium, low potassium, low phosphate, and you must carefully evaluate every single medication for renal toxicity.
Let's dive deep into that pharmacology, starting with the insulin trap. I have a scenario. A patient has had type 2 diabetes for 15 years. They progressed to stage 5 CKD. Over a few weeks, their blood sugars start crashing. They are having severe hypoglycemic episodes. The provider slashes their daily insulin dose in half. The patient is thrilled. They think their diabetes is finally reversing. What is actually happening?
Their diabetes hasn't improved at all. Their kidneys are failing. The kidneys are responsible for degrading and excreting a significant portion of circulating insulin. When the GFR drops in advanced CKD, the kidneys can no longer clear the insulin.
Oh, so it just builds up.
Yes. The half-life of the insulin they inject is drastically prolonged. It stays in the bloodstream for hours longer than intended, driving glucose into the cells and causing profound hypoglycemia. A decreasing insulin requirement in a long-standing diabetic is a massive red flag for impending end-stage renal disease.
That completely changes how I view those hypoglycemic events.
Yeah.
Now let's talk about the domino effect of CKD-MBD, chronic kidney disease, mineral, and bone disorder. This is one of the most complex cascades in the body. How does kidney failure lead to cardiovascular death via the bones?
It is a devastating neuroendocrine cascade. Step 1. The GFR drops, and the kidneys can no longer excrete phosphate. Serum phosphorus levels rise.
Okay.
Step 2. Phosphorus binds freely with calcium in the blood, creating precipitates. This directly drives down serum ionized calcium levels.
Right.
Step 3. At the same time, the failing kidneys stop producing 1-alpha hydroxylase, the enzyme required to convert inactive vitamin D into active calcitriol. Without active vitamin D, the gut cannot absorb dietary calcium, causing serum calcium to plummet even further.
So the body is starved for calcium. The parathyroid glands detect this hypocalcemia. What do they do?
The parathyroid glands panic. They go into overdrive, secreting massive amounts of parathyroid hormone, or PTH. This is called secondary hyperparathyroidism. PTH has one goal: normalize blood calcium at any cost. It does this by activating osteoclasts, which physically break down the skeletal matrix, leaching calcium and phosphorus out of the bones and into the bloodstream.
Which leads to osteomalacia and weakened fibrotic bones. But the real danger isn't the bone fractures, is it? It's where all that leached calcium ends up.
Exactly. You now have high levels of calcium and high levels of phosphate circulating together. They bind to form calcium phosphate crystals, and they deposit into the soft tissues. But most lethally, they deposit into the intimal layer of the blood vessels.
Vascular calcification.
Yes. The arteries literally turn to stone. They become rigid. This calcification deposits into the heart valves, the myocardium, and the coronary arteries. It causes extreme left ventricular hypertrophy, ischemia, and lethal arrhythmias. Cardiovascular disease is the #1 killer in CKD. More patients die from cardiac arrest than ever survive long enough to need dialysis.
So how do we intervene in that cascade? We have to stop the phosphate absorption.
We administer oral phosphate binders, calcium-based binders like calcium acetate or non-calcium binders like sevelamer. They bind the dietary phosphorus in the GI tract, so it is excreted in the stool before it can be absorbed.
Okay, but there's a trick to giving these.
It's a massive one. Here is the critical nursing implementation. They must be administered with meals. If you give a phosphate binder 2 hours after a patient eats, it does absolutely nothing because the phosphate has already been absorbed.
Right, with the first bite of food. We also have to replace the active vitamin D with oral calcitriol, and we have to address the anemia. Why do CKD patients have such profound normocytic anemia?
Because the peritubular interstitial cells of the kidney are responsible for sensing hypoxia and secreting erythropoietin, EPO, which tells the bone marrow to produce red blood cells. As the kidney scars and undergoes fibrosis, those cells turn into myofibroblasts and stop producing EPO. Without EPO, red blood cell production grinds to a halt.
We treat that with exogenous EPO injections like epoetin alpha, but there is a massive intensivist safety trap here. We don't titrate the EPO to a normal hemoglobin of 14 or 15, do we?
Absolutely not. Our target hemoglobin is only 10 to 11. If you push the hemoglobin higher, you massively increase the whole blood viscosity. Pumping thick, highly viscous blood through heavily calcified, rigid arteries causes malignant hypertension, strokes, and myocardial infarctions. You hold the EPO if their hypertension is uncontrolled.
Let's talk about ACE inhibitors and ARBs. We said earlier they are terrible for AKI, but in CKD, they are the gold standard for slowing progression. Why the contradiction?
Because the hemodynamics are different. In early CKD, the surviving nephrons are hyperfiltering under immense pressure. By giving an ACE inhibitor, you vasodilate that efferent arteriole.
The exit pipe again?
Yes. You decrease the intraglomerular pressure. You reduce the shear stress and the proteinuria, which halts the inflammatory scarring process. It is highly renal protective over the long term. However, you must monitor the serum potassium obsessively because blocking aldosterone will cause the body to retain potassium.
Let's look at deterioration. If I have a stage 5 CKD patient on the floor, what tells me they are decompensating rapidly?
The patient is getting worse if they develop an altered mental status. Lethargy, apathy, confusion. This means the uremic toxins have reached concentrations high enough to cross the blood-brain barrier. Seizures and coma are imminent unless they start dialysis immediately.
What else?
You also escalate to a rapid response if you assess muffled heart sounds and hypotension. Just like in AKI, that is the classic presentation of cardiac tamponade resulting from an enlarging uremic pericardial effusion.
Before we move to dialysis, let's log in the end-of-shift handoff for CKD. Give me the 5 intensive takeaways.
Number 1. Core pathophysiology. Chronic hypertension or hyperglycemia causes shear stress and hyperfiltration, leading to progressive, irreversible nephron fibrosis, systemic uremia, and a total inability to excrete wastes.
Got it.
Number 2. Key assessment finding: intractable hypertension, massive fluid overload, severe pruritus, and eventually uremic encephalopathy.
Right.
Number 3, most dangerous complication: cardiovascular disease and sudden cardiac death resulting from widespread vascular calcification caused by the CKD-MBD cascade.
Number 4.
Priority nursing action: strict blood pressure control and rigorous enforcement of dietary fluid, protein, and electrolyte restrictions while vigilantly protecting vascular access.
And the final one?
Number 5, most important treatment: ACE inhibitors or ARBs in the early stages to reduce intraglomerular pressure and slow progression, followed by renal replacement therapy when they reach end-stage renal disease.
What is our one-sentence clinical picture?
A diabetic patient with chronic fatigue, severe hypertension, and intense skin itching presents with a calculated GFR of 12 and a pericardial friction rub.
And the trigger rule.
If you see a patient with advanced CKD taking their first bite of a meal, think hyperphosphatemia, and do ensure they take their phosphate binders simultaneously to block absorption.
Okay, so the kidneys have completely failed, the GFR is below 15, the uremia is poisoning the brain and the heart, the native organ is dead. How do we keep the patient alive?
We replace the function of the organ mechanically.
Yeah.
We initiate renal replacement therapy, or RRT. In the chronic outpatient setting, this is typically standard hemodialysis or peritoneal dialysis. In the hemodynamically unstable ICU patient, we use continuous renal replacement therapy, or CRRT.
When exactly do we make the call to start these machines in the ICU? We don't just wait for a specific GFR number, do we?
No, we look for absolute physiological indications that medical management has failed. We initiate dialysis for severe volume overload that is causing pulmonary edema and respiratory failure. We initiate for uncontrollable, life-threatening hyperkalemia. We initiate for severe metabolic acidosis, usually a bicarb less than 15 that isn't responding to drips. And we initiate for severe uremic complications, like encephalopathy or pericarditis.
Let's break down the actual physics of how these machines clean the blood. It's all about moving molecules across a semi-permeable membrane.
Exactly. It relies on 3 core principles: diffusion, osmosis, and ultrafiltration. Diffusion is the movement of solutes, like urea, creatinine, and potassium, from an area of higher concentration in the patient's toxic blood to an area of lower concentration in the clean dialysate fluid.
Okay, so it just naturally moves over.
Yes, and in hemodialysis, the machine pumps the blood and the dialysate in opposite directions through the filter. This countercurrent flow ensures that the concentration gradient is maintained along the entire length of the capillary fibers, maximizing the clearance of toxins.
What about fluid? How do we get the excess water out?
That's osmosis and ultrafiltration. In peritoneal dialysis, we use osmosis. We infuse dialysate with highly concentrated glucose into the abdomen. The glucose creates an osmotic gradient, acting like a sponge to pull excess water out of the blood vessels across the peritoneal membrane and into the abdominal cavity to be drained.
And for hemodialysis?
In hemodialysis, we use ultrafiltration. The machine physically creates a pressure gradient: positive hydrostatic pressure pushing on the blood side and negative pressure pulling on the dialysate side to literally rip the excess fluid out of the intravascular space.
Let's dive deep into hemodialysis. To pull that much fluid and run blood through a machine at 400 milliliters a minute, you need massive vascular access.
You do. The gold standard is an arteriovenous fistula, or AVF. A surgeon anastomoses an artery directly to a vein, usually in the forearm. The high-pressure arterial blood blasts into the thin-walled vein, causing it to dilate and the walls to thicken and arterialize over several months.
And as the bedside nurse, assessing that fistula is a life-or-death priority.
You must assess it every single shift. You palpate the anastomosis site to feel the thrill. It feels like a distinct buzzing or vibrating sensation under the skin. Then you auscultate it with your stethoscope to hear the brute, a continuous rhythmic whooshing sound.
What if I touch it and I don't feel the thrill?
That is an immediate escalation. You notify the vascular surgeon immediately. The fistula has likely clotted off. Without it, the patient cannot receive dialysis, and they will die of hyperkalemia or fluid overload. They need emergency surgical declotting or a new access placed.
Are there other complications from bypassing the capillary beds like that?
Yes, Steele syndrome. Because you are shunting a massive volume of high-pressure arterial blood directly into the venous system, the tissue distal to the fistula, the hands and fingers, might be robbed of perfusion. It is literally being stolen.
So they lose blood flow?
Yes. You must assess for distal ischemia. The patient will complain of a cold hand, severe pain that worsens during dialysis sessions, and you will see delayed capillary refill.
Let's talk about the hemodynamics of an HD session. The machine is going to pull 3 or 4 liters of fluid out of the patient's intravascular space over just 4 hours. That is a massive drop in preload.
It is a violent hemodynamic shift. The body attempts to compensate by constricting peripheral vessels and increasing heart rate, pulling interstitial fluid back into the vascular space to maintain mean arterial pressure. But if the machine pulls fluid faster than the interstitial space can refill the vessels, the patient will crash.
So what is the priority nursing action to prevent that crash before dialysis even starts?
You must meticulously review their medications and hold all antihypertensives and dialyzable drugs prior to HD. If you administer their morning beta blocker or ACE inhibitor, you are chemically blocking their ability to vasoconstrict and mount a tachycardic response. When the machine pulls their preload, they will have no compensatory mechanisms left, and they will code.
What if they do crash? I'm watching the patient on the HD machine. They suddenly get nauseous, dizzy, and their pressure drops to 70/40. What is my exact sequence of actions?
First, decrease the ultrafiltration rate on the machine immediately. Stop pulling fluid. Let their intravascular volume catch up.
Okay, next T.
Next T. Infuse a bolus of 0.9% normal saline or albumin directly through the extracorporeal circuit to rapidly restore their preload.
Then,
reassess the blood pressure and cardiac output. Do not lay them completely flat if they're respiratory compromised, but you can elevate their legs to increase venous return.
I've also seen HD patients get terrible, agonizing muscle cramps during treatment. It looks incredibly painful. Are they just needing to stretch?
Not at all. These are not regular muscle cramps. This is a sign of severe tissue hypoperfusion. The rapid ultrafiltration depletes the intravascular volume so fast that the muscles are essentially suffocating. Furthermore, the low sodium dialysate causes a massive osmotic shift of water into the muscle cells, causing them to swell and spasm.
Oh, so it's a fluid shift problem.
Yes. The treatment is not just stretching. You must reduce the ultrafiltration rate and administer a bolus of hypertonic glucose or normal saline. The hypertonicity of the bolus acts as an osmotic agent, rapidly pulling fluid out of the swollen muscle cells and back into the vascular space, relieving the cramp and boosting the blood pressure.
That is fascinating. So the protocol is actually a Band-Aid for the underlying physics. Let's shift to the ICU specifically. If standard hemodialysis causes these massive hemodynamic crashes, how do we dialyze a patient who is in septic shock on 3 vasopressors with an MAP of 55?
We use continuous renal replacement therapy, or CRT. This is pure intensivist thinking. The problem is a uremic, fluid-overloaded patient who requires clearance. The failing physiology is severe vasoplegia and cardiac dysfunction. They physically cannot tolerate the rapid 4-hour preload drop of standard HD. It would cause immediate cardiovascular collapse. The intervention is CRT.
How does the hemodynamics of CRT differ?
We use a double-lumen central venous catheter. The machine runs continuously, 24 hours a day, 7 days a week. Instead of pulling blood at 400 milliliters a minute, we pull it at a slow, gentle rate of 100 to 200 milliliters a minute.
Very slow.
Yes. We utilize slow, continuous ultrafiltration and convection. We remove fluid at a rate of maybe 100 or 200 milliliters an hour. It mimics the natural, continuous, slow, and steady pace of the native kidneys. The reassessment is that the uremic toxins clear and the fluid is removed over days, while the patient's MAP remains perfectly stable on their vasopressors.
But because the blood is moving so slowly through that external tubing, doesn't it just clot instantly?
That is the primary complication. You must use continuous anticoagulation to keep the filter patent. We often use regional citrate anticoagulation, and the mechanism here is incredible. We infuse citrate into the blood as it leaves the patient and enters the machine. The citrate binds to all the ionized calcium in the blood. Because the coagulation cascade requires calcium to function, the blood in the filter cannot clot.
Wait, if you were stripping all the calcium out of the blood and then returning that blood to the patient, won't the patient immediately go into hypoglycemic cardiac arrest?
Yes, they would, which is why we simultaneously infuse a continuous drip of calcium chloride directly into the patient through a separate central line port right before the blood returns to systemic circulation.
Oh, wow. So you just put it right back.
Exactly. You are chemically isolating the anticoagulation to just the machine. It requires meticulous hourly monitoring of ionized calcium levels from the machine and the patient to ensure the balance is perfect.
That is the definition of the razor's edge. Let's look at the third modality, peritoneal dialysis, or PD. No blood leaves the body here. We are using the patient's own peritoneal membrane inside their abdomen as the filter.
Correct. We surgically implant a catheter through the abdominal wall into the peritoneal cavity. The patient goes through repeated cycles of fill, dwell, and drain. We infuse 2 to 3 liters of dialysate, let it dwell for hours to allow diffusion and osmosis to occur across the highly vascularized peritoneal membrane, and then we drain the toxic effluent out.
What is our primary assessment priority for PD?
You must assess the effluent, the fluid that drains out. It should be perfectly clear or slightly straw-colored. You should be able to read a newspaper through the drainage bag. If the effluent is cloudy, you have a massive, life-threatening problem.
Cloudy means white blood cells. It means infection.
It is the absolute hallmark of perisonitis. It is usually caused by contact contamination of the catheter connections with skin flora, like Staphylococcus aureus, or enteric bacteria if there is bowel translocation. The patient will also complain of abdominal pain, rebound tenderness, and you'll hear hyperactive bowel sounds.
What is the nursing action?
If you see cloudy effluent, you must immediately obtain a sample of that effluent and send it for a cell count, gram stain, and culture. If the cell count reveals more than 100 white blood cells per microliter with a predominance of neutrophils, peritonitis is confirmed. You obtain the cultures before you administer broad-spectrum antibiotics, which are often instilled directly into the dialysate bags so they go straight to the site of infection.
Are there metabolic complications specific to PD? We are infusing massive amounts of glucose into their abdomen to pull the fluid.
Yes, that dextrose can easily be absorbed across the peritoneal membrane into the systemic circulation. This causes significant hyperglycemia and hypertriglyceridemia. Diabetic patients on PD often require significant increases in their insulin doses to manage the absorption of the dialysate glucose.
And what about protein? We spend all this time telling CKD patients to eat low-protein diets to protect their kidneys. Does that continue on PD?
The exact opposite. The peritoneal membrane is highly permeable to plasma proteins and amino acids. During the dwell time, the patient loses a tremendous amount of protein into the dialysate, up to 10 to 20 grams a day, and even more if they have active peritonitis causing inflammation.
So they need more protein.
Yes. A patient on PD requires a high-protein diet to compensate for these continuous losses. Otherwise, they will develop severe malnutrition and hypoalbuminemia, which will cause massive third spacing of fluid.
Let's do the end-of-shift handoff for renal replacement therapies.
Number 1, core pathophysiology. Dialysis utilizes diffusion to clear toxins and osmosis, or ultrafiltration, to remove fluid across a semi-permeable membrane, utilizing countercurrent flow to maximize clearance.
Right.
Number 2, key assessment. For hemodialysis, confirm fistula patency by palpating the thrill and auscultating the bruit. For peritoneal dialysis, strictly assess the effluent for absolute clarity.
Got it.
Number 3, most dangerous complication. In standard HD, it is severe hypovolemic hypotension and cardiovascular collapse. In PD, it is bacterial peritonitis.
Number 4,
priority nursing action. Meticulously review and hold antihypertensive and dialyzable medications before HD to prevent hemodynamic crashing.
and 5.
Number 5, most important treatment. If hypotension or severe cramping occurs on HD, immediately decrease the ultrafiltration rate and administer a fast IV fluid bolus to restore intravascular volume.
What is our one-sentence clinical picture?
A patient on hemodialysis suddenly complains of severe muscle cramps, profound lightheadedness, and their mean arterial pressure plummets.
And the trigger rule.
If you see cloudy PD effluent and the patient complains of abdominal pain, think peritonitis, and do a pain and effluent culture immediately before starting intraperitoneal antibiotics.
We've managed the acute crisis of AKI, we've weathered the chronic systemic poisoning of CKD, and we've utilized complex physics and machines to buy time. But now we pivot to the ultimate prize, the gold standard treatment, and arguably the most high-stakes 24 hours of a renal patient's life. The kidney transplant. Give me the 80-20 overview.
Kidney transplantation is the treatment of choice for end-stage renal disease. It reverses the uremia entirely and frees the patient from the dialysis machine. It is highly successful, with 1-year graft survival rates over 90%.
But the anatomy is unique, right?
Very. The old fibrotic native kidneys are almost always left right where they are. The new donor kidney is placed extraperitoneally in the iliac fossa down in the pelvis and anastomosed directly to the iliac artery and vein, and the new ureter is attached to the bladder.
Let's focus on the critical care window. The patient rolls through the doors of the ICU straight from the OR. What is the pathophysiology occurring inside that new kidney in that exact moment?
The clamps have just been released. The recipient's blood rushes into the new kidney. This is revascularization. Now remember, this patient's blood is highly toxic. It is packed with built-up urea, creatinine, and electrolytes. As soon as that blood hits the new glomeruli and begins to filter, that massive load of BUN enters the renal tubules.
And urea is an osmotic agent.
A highly potent one. It acts exactly like a massive dose of intravenous mannitol. The high concentration of urea in the tubules forcefully pulls water out of the blood and into the urine. This triggers a massive, profound osmotic diuresis.
Which means they start putting out a staggering amount of urine.
Up to 1 full liter of urine per hour in the first 12 to 24 hours. It is a fire hose.
A liter an hour. That creates an immediate, life-threatening decompensation risk.
It creates the risk of sudden, profound hypovolemia. If the patient is losing a liter of intravascular volume every 60 minutes, their preload is plummeting. If the preload drops, the cardiac output drops. If the cardiac output drops, the mean arterial pressure tanks.
And if the pressure tanks, the new kidney loses perfusion.
Exactly. Renal hypoperfusion is the fastest way to kill a new graft. If the blood pressure drops, the new kidney suffers ischemic damage. You can induce acute tubular necrosis in the brand new organ within hours of surgery. You have taken a healthy kidney and immediately destroyed it.
So our bedside assessment and implementation have to be flawless. How are we managing this?
You are watching the Foley catheter output continuously. You are monitoring the central venous pressure, the CVP, to gauge their exact right-sided filling pressures. Your implementation is a strict 1.1 fluid replacement strategy.
Walk me through the mechanics of that 1.1 replacement.
You measure the exact urine output every single hour. If the Foley drains 850 milliliters between 2:00 p.m. and 3:00 p.m., you program the IV pump to infuse exactly 850 milliliters of 0.9% normal saline between 3:00 p.m. and 4:00 p.m. You are replacing their volume milliliter for milliliter to maintain exact euvolemia.
And what about electrolytes?
You are also monitoring their serum potassium and sodium every few hours, because this massive diuresis will wash out their electrolytes, leading to severe hypokalemia and hyponatremia that you must replace intravenously.
What about the immune system? The body's natural response to a foreign organ is to attack and destroy it. We have to completely suppress that response.
We use a heavy induction phase of immunosuppression in the OR, followed by lifelong maintenance therapy. The cornerstone drugs are calcineurin inhibitors like tacrolimus or cyclosporine.
How exactly does tacrolimus work at the cellular level to stop rejection?
It targets the T cells. When a T cell encounters a foreign antigen, like the new kidney, calcium enters the T cell and activates an enzyme called calcineurin. Calcineurin then activates a transcription factor that enters the nucleus and tells the T cell to produce interleukin-2.
Okay, what does IL-2 do?
Interleukin-2 is the chemical signal that causes T cells to multiply and launch a massive attack. Tacrolimus physically binds to and inhibits calcineurin. The signal is blocked. Interleukin-2 is never produced. The T cells are paralyzed.
But paralyzing the T cells leaves the patient completely defenseless against everything else.
It is the ultimate double-edged sword. You prevent acute cellular rejection of the graft, but you expose the patient to massive risk for opportunistic infections. They are highly susceptible to fungal infections like Candida or pneumocystis jirovecii pneumonia, known as PCP or PJP. They are also vulnerable to viral reactivation, specifically cytomegalovirus, or CMV, which can cause lethal pneumonitis or enteritis.
So we have to put them on prophylactic medications.
Yes, they will often be on trimethoprim sulfamethoxazole for PCP prophylaxis and valganciclovir for CMV prophylaxis. You also have to monitor the trough levels of the tacrolimus obsessively.
Why obsessively?
Because if the level is too low, the T cells wake up and reject the organ. If the level is too high, tacrolimus causes severe afferent arterial vasoconstriction, which is directly nephrotoxic to the new graft.
We also talked earlier about cancer risk. Why does suppressing the immune system lead to cancer?
Because the immune system's job isn't just fighting bacteria. It performs continuous surveillance, hunting down and destroying abnormal mutating cells before they become tumors. When you suppress the T cells, you suppress that surveillance. Transplant patients have a drastically increased risk of skin cancers and a specific highly aggressive lymphoma called post-transplant lymphoproliferative disorder, or PTLD, which is strongly associated with the Epstein-Barr virus taking advantage of the suppressed immune state.
Let's talk about deterioration in the ICU. The patient is doing well, producing 800 milliliters an hour. Suddenly, hour 4, the Foley only drains 20 milliliters. The urine output has halted.
A sudden halt in urine output in a fresh transplant is an absolute surgical emergency. You must escalate. But you have to use intensivist thinking first. The problem is sudden oliguria. The immediate threat is that urine is backing up, causing hydronephrosis, physically crushing the new glomeruli from the inside out. But what is the failing physiology?
It could be a clot.
Exactly. The most common early cause is a mechanical obstruction of the outflow tract by a blood clot in the Foley catheter. Your first intervention is to check the tubing for kinks. If ordered by the surgeon, you perform gentle irrigation of the Foley to dislodge the clot. If the clot clears and the 800 milliliters of urine suddenly rushes out, you just save the graft.
But what if it flushes fine? There's still no urine.
Then the surgeon must evaluate immediately. It could be severe hypovolemia that you missed. It could be a urine leak in the anastomosis site where the ureter connects to the bladder. It could be a renal artery thrombosis cutting off blood supply.
Yeah.
Or it could be hyperacute rejection, where preformed antibodies in the recipient's blood immediately attack and destroy the graft vessels, which usually requires immediate removal of the kidney.
What if the kidney never starts producing urine in the first place? I have a patient who received a kidney from a deceased donor. The surgery goes perfectly. They roll into the ICU. Hour 1, 0 urine. Hour 2, 0 urine. Hour 3, 0 urine. What went wrong?
This is a classic pattern recognition scenario. You have to consider the cold ischemia time. When a kidney is harvested from a deceased donor, it is flushed with preservation fluid and placed on ice. But it is still deprived of oxygen. The ATP stores deplete. If that cold ischemia time is prolonged, say 18 to 24 hours before it is implanted into the recipient, the tubular cells suffer significant ischemic injury. Furthermore, when the blood flow is finally restored in the OR, the sudden influx of oxygen creates highly reactive oxygen-free radicals, causing ischemia-reperfusion injury.
Which means the new kidney immediately develops acute tubular necrosis.
Yes, the tubules swell and obstruct just like we discussed in the AKI section. The graft is alive, but it is sleepy. It has ATN.
So the patient went through the entire transplant workup, the massive surgery, the induction immunosuppression, and they still need dialysis.
Yes, that is a massive ICU pearl. The ATN can last for days or even weeks while the tubular epithelium regenerates. You must maintain their fluid and electrolyte balance with temporary hemodialysis. You have to prepare the patient mentally for this possibility so they don't wake up from surgery, see the dialysis machine, and think the transplant failed permanently.
Let's lock in the end-of-shift handoff for the transplant post-op phase.
Number 1, core pathophysiology. Revascularization and the sudden clearance of built-up BUN initiates a massive osmotic diuresis from the new graft.
Okay.
Number 2, key assessment. Hourly, highly precise measurement of urine output and continuous monitoring of central venous pressure to assess intravascular volume.
Number 3.
Number 3, most dangerous complication. Profound hypovolemia leading to hypoperfusion and ischemic ATN of the new kidney, as well as lethal opportunistic infections from the immunosuppression.
Then 4.
Number 4, priority nursing action. Strict 1.1 hourly intravenous fluid replacement of all urine output to maintain exact euvolemia and ensure graft perfusion.
And finally.
Number 5, most important treatment. Lifelong adherence to calcineurin inhibitors and other immunosuppressants to prevent acute and chronic T-cell-mediated rejection of the allograft.
What is our one-sentence clinical picture?
A fresh post-op kidney transplant patient in the ICU is suddenly draining 900 milliliters of urine an hour, and their central venous pressure and MAP are rapidly dropping.
And the trigger rule?
If you see a sudden halt in urine output in a fresh transplant, think mechanical catheter obstruction, and do check Foley tube patency, and irrigate gently if ordered before immediately calling the transplant surgeon.
So what does this all mean? We started this deep dive looking at a crashing patient in a murky diagnostic landscape. But by walking through the cellular physiology, we've replaced that confusion with an intensivist's clarity. We understand the aggressive priority of protecting the myocardial resting membrane potential from the fatal hyperkalemia of acute kidney injury using calcium gluconate.
Right.
We see the slow systemic poisoning of chronic kidney disease and the critical importance of managing the bone-crushing, vessel-calcifying cascade of CKD-MBD. We've mastered the fluid physics and countercurrent hemodynamics of dialysis and the razor's edge of maintaining perfect 1.1 fluid balance in the immediate transplant window to protect a fragile new organ. You are no longer just reacting to a low blood pressure alarm, you are anticipating the physiological collapse based on the cellular mechanisms and intervening before it happens.
You're thinking like an intensivist. You're connecting the localized tubular necrosis and the systemic immune dysfunction directly to the bedside decisions that save lives.
But before we let you go back to the unit, we want to leave you with a glimpse into the future of how we manage end-stage renal disease.
Right now, standard hemodialysis is a brutal intermittent therapy. It requires massive hospital infrastructure. A patient is tethered to a 200-pound machine for 4 hours, 3 days a week, undergoing violent fluid and electrolyte shifts that leave their cardiovascular system exhausted and chronically damaged. But the future is shifting toward continuous clearance. The future is the wearable artificial kidney.
Imagine taking that massive hospital machine, the dialyzers, the pumps, and miniaturizing it into a 10-pound belt that runs on batteries, a device that connects via a dual-lumen catheter and runs continuously, 247, utilizing microscopic volumes of regenerated dialysate. The patient walks around, goes to work, lives their life, all while the device slowly and continuously ultrafiltrates fluid and diffuses toxins. How will continuous ambulatory dialysis completely rewrite the pathophysiology of end-stage renal disease? If we eliminate the violent 4-hour preload drops and the massive electrolyte swings, will we eradicate the cardiovascular mortality that currently plagues these patients? Will the crashing blood pressures and the agonizing muscle cramps of clinical dialysis become a thing of the dark ages? Will we finally be able to truly mimic the continuous, elegant perfection of the human kidney?
It represents a profound, fundamental shift in the hemodynamics of renal failure treatment. It is the holy grail of nephrology.
Something to mull over on your next shift as you hang that next bag of 1.1 replacement fluid or adjust the ultrafiltration rate on your CRRT circuit. Thank you for joining us on this intensely focused deep dive. Take this 80-20 critical thinking, apply it to the pathophysiology of your next patient, and keep pushing for that aha moment. We'll see you next time.